Good afternoon, everyone, and welcome to today's webinar presentation brought to you by the Heart and Stroke Foundation. We will be discussing today intimacy after stroke. It's part one of the Resumption of Life Roles and Activities Following Stroke webinar series. My name is Elizabeth Smitko, and I am part of the Stroke Best Practices and Knowledge Exchange team here at the Heart and Stroke Foundation. We aren't using webcams in this presentation, so you won't be able to see us. So just a heads up on that front that it will just be a visual show for you with the slide deck, and you'll be just hearing us versus seeing us for the presentation today. So I'm just going to go through some housekeeping slides before we get going, and then we'll dive right into our presentation today. So we do use GoToWebinar. You can listen through the computer or you can listen through the phone. You'll see that you will have that option when you select the audio option in your GoToWebinar panel. If you are using your computer, just a reminder to turn your speakers up, as sometimes people don't realize that they will need to do that in order to hear us. Just a friendly reminder. If you have questions and comments, please send them to us throughout the presentation. We do encourage you to send them throughout so we can get right into the question and answer period at the end of the presentation. We are recording the session, so all of our recordings are available on the Stroke Best Practices website on a webinar archive. So we do send out the recording along on its own after the presentation, but all of our previous webinars are also located on the website. Slides for the presentation are not available, just the recording. And then just a reminder that if you are experiencing any feedback, just to make sure that your cell phone or your telephone or your speakers aren't located near each other, because that may be the cause of it. There will be a survey sent out if you wouldn't mind completing the survey. This is how we come up with topics for today's presentation, where we're able to deliver information that you want to hear about. So please, we encourage you to complete those as they do inform future presentations. And then we do have an upcoming presentation. As mentioned, this is a series. So our next presentation is on rehabilitation and driving. The presenter is Michael Camarada from McMaster University, and it's taking place on April 25th at 3 o'clock Eastern Standard Time until 4 o'clock Eastern Standard Time. The registration information will also be sent to you in a follow-up email that will include today's survey and recording. And now I'm going to get into our presentation for today. So I'm pleased to have join us today Tracey Palmer, a registered nurse from Ottawa Hospital Rehabilitation Center, and Shawna McCusker, a registered social worker from the Trauma and Bariatric Center of Excellence at the Ottawa Hospital. I'm going to pass things over to them so we can get right into our presentation.
Okay, so hello Canada. Confirm that we have not received financial support, we have not received any in-kind support, and that there are no potential conflicts of interest with our presentation. So the goals of today's session is to increase your basic knowledge of sexuality and intimacy, and then in turn to increase your awareness of some of the relevant issues around intimacy and sexuality post-stroke. Shawna will review some of the work being done to address post-stroke intimacy concerns, and then I will follow up and discuss a process that has been devised to look at self-reflection in the context of providing sexuality education. And then at the end of our handout, you'll note that there is additional resources for healthcare providers, stroke survivors, and families. So while we did our lit search, we came across an article from Schmitz and Finkelstein that identified 7 key themes related to sexuality issues and the role of rehab in addressing these issues. So the first is a sense of loss and functional change that affects sexuality. So here we're talking about not only physical losses, but also psychological losses, fears, maybe a sense of isolation, fear of another stroke, and that these losses also create a potential fear of failure. The second theme identified is that relationship changes affect sexual functioning. And so often after a stroke, the couple dynamic does change. There may be a role change that's required. One's sense of masculinity and femininity might be disrupted. They may be having to change life goals, future plans, and they may also have to deal with one of them becoming a caregiver. The third theme that was identified is that they find it difficult to talk about sex. The fourth theme, there was little or no discussion of post-stroke sexuality by the rehab professionals. And one couple actually stated that they thought that since the topic wasn't brought up, sexuality, must be discouraged. And so they didn't bring it up either. They felt that there was a need to tailor the education to the individual and the couple. So not generic education, but sort of something that met their needs specifically. Timing was key to presenting the information, and from what the research is showing, either the end of rehab as they're finishing up their rehab or after discharge, they felt was the best timing. And they also felt that they needed to have a rapport with the provider of the education, and they wanted the educator to have some sort of competence. So those were the themes that came up in the literature in terms of what the needs are regarding sexuality education. So the first thing, our first goal was to look at sexuality and intimacy. And so what we chose to do was give you a little bit of information about what is sexuality versus sex versus intimacy. So sex is more what we do. So it's the kissing, the holding, the hugging, the intercourse, the oral sex, anything that we're doing. And this evolves through our lifestyle, or through our life also. If we think back to our sex and sexuality in our 20s versus in our 40s and our 50s, you can see that it has evolved through time. And the other important thing to note is that the more narrow one's definition of sexuality is, the higher the risk of dissatisfaction. And so if one's goal of good sex is always mutual orgasm, you can see that through the years, as our bodies change, this may or may not be possible. And so if that's our be-all, end-all, the chances that we're going to be dissatisfied with our sex and sexuality is fairly high. And so if we're able to help people elaborate on what sex, sexuality, and intimacy can be, I think our risk of people being satisfied is a lot higher. So if sex is what we do, sexuality is who we are. So it's our biological makeup. Are we man? Are we woman? Are we trans? Or do we even identify? Some people don't. It's our emotions, our feelings, how we're coping. It's how we interact with others. So the social component. It's also things like, how did we learn about sexuality? Was it taboo, or was it open? Was it something beautiful? Is it something dirty? So all of that impacts who we are when in terms of sexuality. And some other beliefs are that sex may be for the young and healthy only. And so when we're talking in the context of post-stroke, if people share those beliefs, then obviously we're going to have a little bit of work to do to help them see that sexuality certainly can exist for everybody. And so the importance of sort of delving into what people's beliefs are is important also. And then intimacy rests on a much broader foundation, a relationship of trust, open and honest communication with shared goals, expectations, a mutual respect and concern. Often we communicate this in verbal and nonverbal ways. And it's how a couple connects with each other and they enjoy their closeness and their uniqueness. And this comfort in terms of intimacy can often help the couple open up to new ideas after a stroke, maybe to try new things. If we've always done things the same way in terms of our intimacy and our sexuality, after a stroke we need to sort of broaden those horizons a little bit and maybe be a little bit more creative. And so in the context of a relationship, that can be easier when that mutual respect and trust is there. So Woods developed a sexuality model that's made up of 3 intertwined spheres. And we decided to model our presentation on this format. We liked that we felt that it was all encompassing of really what sexuality, sex, and intimacy are. And so this is the model that we're going to follow to present. So if we look at the first, the sexual self-concept up at the top, this helps a person decide how they're feeling. Are they feeling lovable? Are they feeling worthy of love, capable of love? And post-stroke, you can see that there could be some issues there. Number 2, sexual function. So that's basically how our body how our body responds to sexual stimuli. So here we're going to discuss the sexual response cycle. And then sexual roles and relationships are all the relationships. So our sexual, social, family, colleagues, also our experiences, and all of this really forms the person that we are. So we'll start talking about sexual function. We'll look at the sexual response cycle. And what's found in the literature is that there can be interruption or issues in terms of all of the levels of the sexual response cycle. So there can be elements in terms of desire that are affected. And in there also the ability to initiate or to receive the messages of a sexual experience. There can be erection abilities, and for women, lubrication and clitoral engorgement issues also. Inability or difficulty to ejaculate is also a possibility post-stroke, and then orgasm can be affected also. So there is an interaction between the biological, psychological, and social, cultural, societal norms in terms of our interest and motivation to engage in sexuality. So one research study that I read from Brandstater and Kim actually stated that 1 year post-stroke, 38% of men were having normal erections. So that means that 62% weren't. And so that can be addressed. 22% of men were ejaculating. So that's a large percentage that weren't. 58% were reporting sexual problems, and only 11% were able to achieve orgasm. So there's a lot of education needed with regards to the sexual response cycle itself, and there's a lot of issues that stroke patients are reporting post-stroke. So that's the sexual response cycle, but there's so much more to it than that, and there's so many other challenges that this population is faced with. One being their long list of comorbidities, and with that goes the medications that they're on. So if they're diabetic, that may make some of the issues even larger. If they're having trouble with their blood pressure, blood sugars, cholesterol, so all of those can have an impact on the sexual response cycle. After stroke, there's often altered mobility, strength, and balance, and so they may need some coaching in terms of what options are available for positions. Are there devices out there to help them with positions? Sometimes introducing toys or vibrators may help with their strength and their endurance. And also, they may have to become the more passive person within the partnered relationship. So helping them cope with that also. Oftentimes altered sensation and or hypersensitivity. So again, they're dealing with this challenge from a sexual perspective. They may need some education in terms of body mapping exercise, trying to figure out what feels good and what doesn't feel good after a stroke because of these changes to sensation to their body. and maybe exploring new ways and different touches may help also. Changes in bowel and bladder also become a huge concern post-stroke. And so the risk of incontinence, how to negotiate that. So they'll need education like reducing their fluids, making sure that they toilet prior to intimacy, assuming positions that put less pressure on the bladder. So those are some of the tips and tricks that we can share with them. Fatigue is an issue, medication and side effects, so having the doctors reassess if there's other medications that have less sexual side effects. Fertility for men, if we're saying that such a low percentage is able to ejaculate, fertility will be an issue. And for women, maybe the use of birth control may be an issue, and so that'll have to be negotiated with the doctor to reduce the risk of any potential restroke or clots. Change in visual fields, so working with the patient and the partner to negotiate an approach. Memory changes, so having, trying to keep them in the moment, refocusing. Speech will be a huge issue, so finding new ways to express or to show their emotions or what they're feeling. And emotional lability, and again, that could be difficult for the patient, but also for the partner in terms of sexuality. So I'm going to turn you over to Shawna and let her continue.
Hi there. So when we're talking about relevant issues around intimacy and sexuality post-stroke, we also need to consider the element of sexual self-concept. And we often see that post-stroke there can be an inability to perform according to previous expectations. So this can have to do with traditional gender roles that are taken within relationships, any loss of employment or loss of income that happens, and a general loss of independence. There's often a decreased sense of control over the mind, the body, the health, and even life in general. And with that can happen some lowered self-esteem and overall sense of self-worth. Any alterations in physical appearance can lead to some body image concerns and a perceived sense of sexual desirability, an altered sense of self or a loss of identity, and this has been referred to as a feeling of estrangement from the former self. We also see that there's an increased propensity for depression, anger, irritability, and intolerance post-stroke, which can lead to feelings of guilt, despair, and low self-esteem. We also need to consider the issues related to sexual roles and responsibilities post-stroke, where there can be a role shift, one from general independence to one of dependence, and a shift from an adult-to-adult relationship or intimate partner relationship to one of more carer and patient, and a dependent sick role by the affected partner. There's an increased dependence on the non-affected partner for what would normally be self-care activities. And all of this can contribute to altered self-concept, sexual confidence, increased vulnerability, and reduced sexual communication overall, or even an ambivalence towards sexual contact. When there are effects of impairments in sensory motor function, some of this can affect the self-care on the partner. There can be a fear that another stroke will occur, both within the patient or the individual who has experienced the stroke and their partner. There can be a belief that an active sex life belongs really only to, and I have this in quotes, healthy people, or a lack of perceived sexual desirability. There's often reduced social interactions and social isolation. And for those experiencing aphasia, we know that communication skills are essential for forming and maintaining social and sexual relationships. So this can lead to difficulties in sexual communication within the partnership. There can be pre-existing cultural and religious beliefs or sexual attitudes. And we need to consider the overall sense of meaningfulness and comprehensibility and manageability of the new life situation, both for the affected partner, or the affected person and their partner. So when we consider sociodemographic factors with regard to sexual dysfunction post-stroke, we do know that age and/or gender are not independently related to sexual dysfunction occurrence. There is no clear correlation with marital status, marriage partnership duration, or educational level. What we do know is that an active sexual life before stroke is a major determining factor for sexual activity after stroke. So we need to consider the Canadian stroke best practice recommendations when it comes to providing the best form of care for our post-stroke patients. And what the recommendations tell us are that patients should be given the opportunity to discuss sexuality and sexual functioning with their healthcare provider. Discussions should occur during acute care, rehabilitation, and as the patient transitions back into the community. Both verbal and written information should be provided and adapted to patients who have communication limitations such as aphasia. Patients and their partners should be offered education sessions that address expected changes in sexuality, strategies to minimize sexual dysfunction, and any frequently asked questions. However, in practice, we see that this is not the case. Across cultures and stroke severities, patients after stroke do want to learn and talk about sexual health, but they are not receiving the information that they want from healthcare providers. I've included two excerpts from studies which suggest that in one, 81% of patients report receiving insufficient information about post-stroke sexual dysfunction. And then more locally, at a hospital in Toronto, it was identified that close to no patients were given the opportunity to discuss their sexual health concerns. Some of the potential barriers identified for providing intervention would be that there's typically no standardized point during the rehabilitation stay at which sexual health concerns are discussed with patients. Instead, the onus is placed on the patient and or their partner to approach a healthcare provider with their concerns. And this can be difficult for a whole different number of reasons, either the taboo nature of sexual health in general or their lack of awareness that this is something that they can seek help for. Unlike other commonly addressed stroke rehabilitation issues, sexual health does not tend to have clear ownership among any team members. Some interventions addressing post-stroke are out there, but they are limited. Some research studies have demonstrated improved sexual health for patients using one-on-one counseling and the provision of information booklets, while other interventions have consisted of patient education sessions following discharge from hospital. We do know that both an individualized sexual rehabilitation session and the provision of generic written material in the inpatient setting have been shown to be equally effective in improving outcomes. I wanted to draw your attention to a pilot project that was developed at the West Park Healthcare Centre in Toronto. And this was a project with the aim to provide all stroke rehabilitation inpatients with the opportunity to discuss sexual health concerns with their healthcare providers. Some of the changes implemented included a reminder system, standardization of care processes for sexual health, patient-centered time points for the delivery of sexual health discussions, and the development of a sexual health supported conversation tool for patients with aphasia. By the end of the 10-month project period, the percentage of patients provided with the opportunity to discuss sexual health during their inpatient rehab stay increased to 80%. In this project, it was the occupational therapists on the team who proposed that discussions about sexual health concerns could take place during their intake assessments. A paper-based checklist was already being used to keep track of issues that they addressed with their patients, and sexual health was simply added to this checklist as a reminder mechanism. A script was provided for all of the occupational therapists with 4 basic components. The first was to normalize the situation with statements like, often people after stroke will have concerns about sexual functioning, intimacy, and relationships. They were then to give examples to help patients understand what it was that they were trying to address. For example, people might have questions like, is it safe for me to go back to intimate and sexual activities with my partner? Or concerns like, my relationship with my partner has completely changed. They then offered to listen to the patient's concerns by suggesting or stating things like, we want to help you because sexual health is an important part of being healthy and having a good quality of life. And then following that up with, do you have any concerns right now? If patients did not have concerns at the time of the discussions, they were informed that they could be free to bring up the concerns later or at any time in the rehab process. And lastly, occupational therapists were to inform their patients of other resources that they could access to learn about sexual health after stroke. To address the specific issue of patients with aphasia, a visual supported conversation tool for sexual health was implemented to allow patients to also have the opportunity to discuss their sexual health concerns. In this case, however, it was the speech-language pathologists who used the supported conversation tool to screen patients with aphasia about their concerns. And then what happened was during those team rounds, occupational therapists and speech-language pathologists communicated to ensure that no patients were missed. This is an example of the supported conversation tool that was used by the speech-language pathologist to introduce the idea of sexual dysfunction after stroke and to offer the opportunity for patients to bring up their concerns. At the end of the day, this quality improvement project successfully implemented the Canadian best practice recommendations for stroke care with respect to sexual health, and that is why I highlighted this within our presentation. These are some of the additional tools that can be used for persons with aphasia to address different kinds of issues with changes in desire, mechanics and positionings, the types of things that Tracey introduced earlier. And there's also an intimacy and relationships tool that can be ordered by family physicians to discuss with their patients. So a review of the findings is that sexual dysfunction is a common problem after stroke. The Canadian stroke best practice recommendations do identify the need for stroke patients to be given the opportunity to discuss sexuality and sexual functioning, as well as any concerns they might have with their healthcare provider. There are a number of different intervention strategies that can be taken, including systematic implementation of discussion opportunities throughout inpatient stays, or one-time outpatient education sessions post-discharge from hospital. We do know that an accurate diagnosis and implementation of sexual dysfunction management as part of comprehensive stroke rehabilitation protocol does enhance the emotional and functional outcome in stroke survivors, which ultimately improves overall quality of life. I'm now going to hand it back over to my colleague, Tracey, to go over some of the barriers to providing sexuality education. Thank you, Shawna. So now that we've identified that there is a need to provide education to our stroke survivors and partners or partners, what are some of the barriers that we're facing and why aren't we providing this education? Hopefully after I review this list, you'll find yourself in here for one of these reasons, maybe more. So what the literature is showing is that it's not my responsibility. So I'm a nurse. I'm not comfortable with it. I think the doctor should do it. The doctor doesn't feel that he has all the answers. Maybe the occupational therapist should be doing it. So we're passing the buck, and in the end, it's not being done. Time and resources. We're all so busy in our day, and it's adding one more element of education that's required. And also privacy issues. Where would I find a private area to discuss this? Language barriers can be an issue, especially, or communication barriers with the aphasic patients also. Worry about causing offense to our patients and partners. Fear of opening a can of worms and then not knowing what to do with the questions that people have thereafter. There's a lack of availability of written information. There's no access to any training. We're waiting for the patients to ask. They're waiting for us to ask, and so the concern isn't being addressed by anybody. We're afraid that the service user may sexualize the consultation or the conversation that we're having with them at the time. Lack of knowledge of the impact that a stroke may have on one's sexual function, and comfort in terms of ability to talk about sexuality with other persons. Concerned about the reactions, it says parents, it should be patients and or staff, afraid to shock them, not comfortable with how staff may perceive you if you're willing to bring up the topic of sexuality with your stroke survivors. Lack of availability of policy guidance. So what do our institutions say about discussing sexuality with our clients? And too embarrassed or personally not comfortable discussing
sexuality, or I'm too young and the person is too old, or they're old and therefore they're not sexual. So there's a whole slew of reasons why we're not talking about sexuality to our clients. But certainly if we want to provide best practice, we need to overcome some of those barriers and start putting ourselves out there to providing education and to meeting the specific needs of our clientele. And so myself and Dr. Viola Polomino, Associate Professor at the University of Ottawa, came up with a three-pronged approach to overcoming the barriers that we find we're dealing with that we face when we're trying to provide sexuality education. Initially, it was written, this approach was written for nurses, but really it's for any healthcare professional out there who's willing to step up to the plate and maybe start providing education to their clientele. So the first prong of the three-prong approach is looking at our comfort level. So you'll remember back to the barriers, and basically what we did is broke it down into three areas as to why people aren't providing the education. So lack of comfort was a big one, our attitudes about sexuality, and lack of knowledge. Those were the three themes that we noted in the literature. And so the second being our attitudes, the third looking at our knowledge base about sexuality and providing sexuality education. So then what we did is we decided we would offer some tips and tricks on how to work on these barriers that we're feeling in hopes that we could provide education in the end to the clientele. So looking at our comfort level, we looked at knowledge. Knowledge is power, so the more we seem to know about a subject, the more likely we are to incorporate it into our practice. And so gaining knowledge about sexuality and whatever clientele you're working with, in this case it would be stroke, will help you feel more comfortable. Saying the words that make us giggle, saying them out loud, masturbation, penis, whatever else makes us, vibrator, whatever else makes us sort of giggle and blush, say the words out loud. Say them, within the context of a safe environment, so that in the end, it's not any different than saying leg or arm, and expect to be embarrassed the first few times actually, and you'll be fumbling with your words, and that's normal, but it's like anything, the more times that you put yourself out there and offer this education, the more comfortable you're going to become, and you'll develop your own ways of doing so. It's okay not to have all the answers. I think we should all be used to that in our practice, but knowing where to look for the answers is important. But not having all the answers is not a reason not to put yourself out there and provide this education. Do some role playing with your peers, and that certainly will help. Again, use the words and discuss the topics that we're not comfortable with. Doing group discussions through case studies. I wrote seek out this expert on your unit or department or within your group of professionals who might be the most comfortable, who does have the most knowledge. Introducing the topics by putting them in context. When we talk about sexuality and sexual health, it is an indicator and contributor to health and overall quality of life. And so when we talk to our patients and let them know that this is why we're asking, it certainly puts them more at ease and puts us more at ease also. Practice, practice, practice. Like I say, the more you put yourself out there and ask the questions and engage the client, the more comfortable you're going to become with the topic itself. And then for nurses out there, I kind of like this one. When did talking about people's BMs become our normal? I mean, when we first started, I work with spinal cord injury, so we're talking bowels all the time, consistency. Did you go today? How much? What color? And back then, when I first started, that wasn't comfortable. Now it's like our normal. And so hopefully at some point, addressing sexuality, sexual health issues will become normal also, and your comfort level will go up. The second prong is looking at attitudes. We all have attitudes with regards to sexuality, sexual health. And it's not saying that we want to change all these attitudes. It's just making us aware of what these attitudes are that we hold. And so by becoming aware of our attitudes, it will also improve our comfort in terms of discussing sexuality and sexual health. There's many self-reflective validation questionnaires that are available out there. If you'd like a couple of recommendations, just send me an email and I'll send the titles off to you. Just to look at what our attitudes are in terms of sexuality. In turn, that'll make you aware of what your personal beliefs and attitudes are. And again, it's not looking to change them, it's just making you more aware of them. I think being non-judgmental when we discuss sexuality and sexual health is very important. And in saying that, not making assumptions is also important. Assuming that everyone over 80 is not sexual is an assumption because it's not true. Assuming that people with disabilities are asexual, which is what a lot of people believe, is not true. So not making assumptions and not judging is very important when you embark on this endeavor to provide sexuality education. Using gender-neutral language. So as opposed to, oh, is your wife visiting today? For someone who's heterosexual, that will automatically is going to sort of turn them off a little bit. And so, you know, if your partner visiting today may be the better way to go. So thinking about some of the words that we're using when we engage with our clients is important also. Knowing our limits and referring accordingly. There's certain areas that even after 20 plus years of talking about sexuality with clients, there's still certain areas that I'm not really comfortable with. And I know what they are, and I will refer accordingly. So it doesn't mean that you have to push your own limit. It just means that you need to be aware of what your limits are. Being aware of varying cultural beliefs and practices, and that's with regards to sexuality, but it's also with regards to disability and sickness, because different cultures have different beliefs in terms of all of those. So just gaining some knowledge. There is research out there. That's a good way to do it. And again, using neutral and normalizing statements will help put the patient at ease also. So the third prong of our three-prong approach addressed the lack of knowledge that we all feel that we have. So different approaches, different things that can be done is being inquisitive, ask questions. There's often people out there that may know a little bit more than you do. Be inquisitive, talk to them, read. Here at the Ottawa Hospital, we have access to an amazing library where we can submit a lit search question, and in no time will be sent, 10 articles, and that includes any of the articles on sex, sexuality, and intimacy. We've been very fortunate, and so I would encourage you to see if you have that available to you also. If not, local universities can help also. Seek out the experts in the field. Oftentimes, nurses, doctors, social workers, psychologists, because when we look at sexuality, it really is who we are. It takes many professionals to sort of address the issues that our patients are having, and so we all have a little role to play. Again, it's okay not to have all the answers. Just be aware that there's a lot of models and frameworks out there that will help guide your education. So again, via lit search, you can ask the question to see what's out there for your specific population. And when I provide education, I always go from least sensitive to most sensitive. And again, that helps develop therapeutic relationship and comfort with either the client or the couple. And asking open-ended questions, such as many of our patients have questions about sexuality. Do you have any questions presently that we could discuss, or what are you dealing with or facing on a day-to-day? So asking those questions to the patient. So things to consider: never assume heterosexuality. Don't make assumptions based on gender, age, religion, culture, diagnosis, or partnership status. Consider the partner and the possibility of caregiver stress and burnout. Do not judge. We're not aware of pre-existing dynamics within the couple. And post-stroke, they're not going to go away, so we need to be aware of that. Always addressing safety first, providing reassurance for the fears that either the client or the couple may have. Judge whether you think an individual meeting versus a couple meeting may be useful. Again, oftentimes I'll let the individual decide. Focus on their abilities and their strengths versus what they're not able to do or what they have lost. And redefining the goal. Is sex and sexuality and intimacy about pleasure and closeness, or is it about orgasm? And sometimes we have to redefine that goal with the patient. So in conclusion, the factors that contribute to the decline are the direct pathophysiological effects of the stroke itself, the presence of comorbidities, which often can be quite extensive, the side effects of the medication, and the complex emotional reactions that often include clinical depression. And so when we go back and look at what is sexuality, it really is all of that, and it post-stroke can be affected by all the different spheres of us as sexual beings. So some points to ponder. I'll just leave that up there for you to review, and just to let you know, at the end of the presentation, we've included a lot of resources that you have access to in the PowerPoint, and also some of my favorite books that I use when I provide education to either groups, couples, or individuals. And so you have the ISBN numbers there to help, and a fairly extensive bibliography with a list of really good articles that are up to date and you may find useful. Questions or comments? I guess, Elizabeth, this is where you help us out.
Yeah, thank you so much for that great presentation. We've already received a lot of questions and a lot of comments. Everyone really valuing all of the resources and information that you provided. So thank you very much to both of you for taking us through that. And for anyone that does have questions, please send them through the question box and we will try to get to them right away. We have 15 minutes or so for Q&A, so we can jump right into it. The first question we have is, are you aware of any online education programs that exist on intimacy post-stroke?
I don't know of any specific to stroke, and I did go on to look, and I really didn't find very much, but if you look at the resources that we offered, there's a lot of good books that are out there. The one thing that I'll bring to your attention is there's also a two-part course given through BCIT. That's British Columbia Institute of Technology, and it addresses sexual health rehab, and it helps the professional sort of muddle through all of the comfort knowledge and attitudes, and helps you develop a teaching plan for your patient population. So I have taken it, and it was very valuable. So if anyone's interested in sort of going that next step in terms of providing the education to the clientele, I would encourage that. It's not cheap, but it was very, very resourceful and very good.
Thank you. So there are a lot of people asking about the resources that you provided. So we do not provide a copy of the PowerPoint presentation. So we may though have, if you don't mind, Shawna, if you could put together a list of some of the resources, and we can just send out that list with the survey and the recording that goes out.
Sure, that's not a problem.
Great, thank you very much. So just diving back into the questions that we have here, how would you suggest bringing up the topic of intimacy with a stroke survivor? Should you stay away unless it's brought up?
Definitely not. What the literature shows is they're waiting for the professional to bring up the topic, and the professional is waiting for the client or couple to bring up the topic. And so the literature says a couple of different things. One, some people include it right in their intake. So where they're doing their head-to-toe assessment, bowels, bladder, all of that other stuff, they're bringing up that there can be changes in terms of sexual health and sexual function, and just letting the patient / couple know that there are resources available when they're ready, and that it will be addressed again later. So some people do it right at their initial intake so that the couple is aware that it will be brought up. Other people wait a little bit closer to discharge or before the first weekend pass, where they might address it there so that there's not big surprises and discouragement during the first weekend pass. And then others are bringing it up once they're outpatients. And honestly, there's value to all of them, because initially it's good that they're aware that there are services, but often they're so overwhelmed that that may not be the time that they feel ready. Definitely before a first pass out together, it would be very important. But then it's not all resolved with a 1-hour meeting, because then once they do have time to experiment, that's when they're actually finding what some of the issues are. And so a follow-up thereafter is a good idea also, just to help them work out some of the issues they may be having with positioning, erectile function, whatever it is that they're dealing with. So
absolutely. And just to add to that, I think it's very, very important to normalize the situation right at the outset, that this is a part of the process. This is something that there are resources for, and it's not something to shy away from asking for assistance with. So as Tracey said, sometimes putting it out there at the outset that this is part of the process, and then not forcing the conversation, leaving that with the patient or with the partner to sort of consider as they go through their rehabilitation process. At the acute, during the acute care stay, it's often, as Tracey said, not on the forefront of the mind, but as you move away from that and as you get closer to heading home and moving through your rehabilitation stay or process, at least knowing that it's something you can bring up is very, very important.
Great. And what are your recommendations if a patient tries to sexualize the discussion?
Well, I would just let them know that one is normalizing it again, that we have this discussion with everybody, because often there are changes. And so if you're not comfortable, I would definitely let them know that I'm not comfortable with the tone, and this is what I have to offer, and this is why we offer this service. And I would just carry on. Oftentimes when they sexualize it, especially from being a nurse on the unit, when some of those comments are being made, often that's a cry for help. They want to know, they want more information, and that's their way of asking for it, or their way of seeing if they are still sexual beings. And so it's important to acknowledge what they're feeling, and to let them know that maybe this isn't the format, but certainly we do provide sexuality education, and that you would gladly sit down with them and answer their questions. So again, I wouldn't panic and run out of the room. I would let them know that what they're feeling is very normal and that we can discuss it.
Great, thank you. And do we know anything about follow-up on quality of life for the individuals or perception of care measures?
Sorry, I don't understand the question. Do we know anything about follow-up in terms of?
Yeah, sorry. There's just a question around for the study in Toronto.
Okay.
So with the study in Toronto, do we know anything about the follow-up on quality of life for the individuals involved in the perception of care measures?
It was a recent study, so I don't think there's been any follow-up to date, but I do know that they have continued to implement the system. Okay,
great, thanks. And then there was a question here about the GUO and all study. Was it a rehab or an acute care setting that it was completed in?
The West Park, that in Toronto, that was a rehabilitation program.
Okay, and the best practice recommendations suggest that intimacy post-stroke should be discussed in acute care but is this really the optimal time to discuss the topic?
I think it's a good time to just let them know that there could be issues. Again, not all of our stroke survivors are 60, 70, 80 years old, and so depending on age also, that may be at the forefront. Again, I don't want to stereotype, but I think it's just, even if all you're doing is letting them know that along the way there will be education provided because there may be changes, that may be all that they need at that time. But for some people, it's really on the forefront of their mind, and so there's no harm in at least introducing it that way in the acute care setting. Odds are that that's about as far as it will go because of all the other issues at hand, but it's good to at least sort of let people know that that support will be available to them.
Just including it in the conversation about any expected changes that an individual might experience after stroke. This can be part of that normalized conversation that, you know, in addition to all of these other things, a change in sexuality or sexual dysfunction can be an issue as well. And then leaving it with the patient to sort of consider, and if it's something they want to bring back up earlier versus later, then they have the opportunity to do so.
Great. And could you give examples of least sensitive subjects and more sensitive subjects in your education?
Well, I think when I'm talking least sensitive, I'm sort of globalizing sexuality as a whole. You know, looking at relationship issues and communication, when I'm and partnered relationships and coping and things like that. When I'm looking at more pointed, sensitive topics, I'm talking more about how are you going to manage your bowels and your bladder specifically. What are the options out there for erectile dysfunction? What medications have a specific impact on desire and ejaculation? So going from more generalized, you know, how are you coping? How's your communication? Have you had a chance to be intimate? Those are sort of more global. And then more sensitive is really diving into what some of the issues are that they may be having. But again, I find before I dive into the more intimate issues, I like to at least have developed a bit of a therapeutic relationship with the clients or the couple so that we're comfortable with each other and we're okay to share, you know, they'll feel comfortable sharing exactly what they're living.
Great, thanks. And our last question here, we have a student who's studying sexual health in post-ACS patients and is interested in how closely these points generalize to patients who may have had a heart attack. Any comments on that?
I do. So, you know, my background, as in your introduction, is not in stroke. My background is actually in bariatric surgery and trauma, and I think the significance of quality of life, or the significance of sexuality for quality of life, is generalizable to everybody and in all areas of healthcare. I mean, some of the specifics will shift, but you know, for example, some of the issues that contribute to sexual dysfunction and sexual functioning from a physiological perspective are generalizable, right? We're talking about circulation, we're talking about the mind-body connection, all of those sorts of things, which really you can apply to everyone in all cases. And I think the most important piece to take out of this whole presentation is the real importance that needs to be placed, or the value that needs to be placed on having the conversation and giving people the opportunity to ask questions and talk about it. And if you need more specific information around the specific condition or the specific disability, then you can look into that at a later date. But you know, or say, you know, I don't have the answer right now, but I can come back to you with that. At least offering that opportunity to open that discussion is what is most important.
Great. So that was our last question. Thank you again to the both of you for that very informed presentation. And thank you to everyone who joined us today. We hope you enjoyed the presentation, and we will send out, as mentioned, a recording and a survey. If you would please complete that as Your feedback contributes to future presentations. And thanks again to our speakers today, and have a great day.
Thank you.
Bye now.
Bye-bye.